Always takes me a moment to figure out the Zoom part. So, good morning, everybody. It's really great to be here to have this opportunity to speak to you. I usually work with chronic pain a bit more, so I'm happy to see your experiences. I think there's a lot of crossover themes and information is very consistent about the drugs, etc. But love to hear your experiences in the emergency department and see what kind of issues are you faced with. Yeah, really looking forward to this conversation about pain management and older adults. So this is obviously as I told Kelly earlier, that it's a huge topic. I think we can probably go in all sorts of directions and talk about it for hours. But today I'm going to just focus on reviewing pain presentation and assessment for older adults, and then talk a bit about the evidence for treatment, both pharmacological and non-pharmacological approaches. So this is a quick review for you on pain physiology. So you can see that on the left-hand side here, there's a hand, and then there's injury to the tissue from a nail. So the key thing to remember here is that the pain is a sensation. So it is sensed in the brain, and it becomes integrated with memory, expectation, emotions, etc. So that the intensity of pain can feel different for different people, even in the same person when they're experiencing different life events or at different stages of life. So this can change from less bearable to more bearable depending on the individual circumstances. Personal experiences, things like culture, religion, life circumstances can all play a role. So even the language we use, pain versus discomfort, can take on different meaning for different people. So here, when the injury happens on the hand, pain starts with a stimulus, and then in the hand, it goes through to the peripheral nervous system, and then the synapses in the dorsal horn right up here, and then it travels up this spinal thalamic tract to synapse in the thalamus and then medulla, and basically involves multiple areas in the brain. And this is where the pain is perceived, and a lot of the modulation will take place. So modulation can help to inhibit pain transmission, so the response to the pain that the person experiences. And this modulation can also happen in the dorsal horn. So pain can be modified, as I mentioned, by various things like our memory, life experiences, emotions, etc. So if your patient is anxious or lonely or scared or bored even, they might feel a more intense pain. The pain perception could get worse, and it can be harder to manage that pain in that situation. If they're distracted or happy or relaxed, meditating, etc., their pain perception can actually be less. So this is why sometimes people use distraction as a modality to help manage pain. If you're with a patient, if you're speaking to them, if they're with their family members, you might find that they're experiencing pain or complaining of pain a bit less, but that doesn't mean the pain is less real. So the because pain takes on such personal interpretation for the person, for example, the pain of childbirth and the pain from cancer can be quite different because they perceive the underlying meaning to be quite different. And also just knowing that one is temporary somewhat and the other may not be. Um, so uh, one other example that people have given in the past, I've heard in other presentations, is that even sometimes when patients know what their pain is from, so when they have a lesion that they're not sure what's causing it, they can feel more pain. And once they find out whether it's malignant or benign, somehow that can decrease pain perception as well and make it easier to manage that pain. So speaking of different types of pain, I'm sure you're all familiar with this. Nociceptive is a response to tissue injury or inflammation, and then neuropathic tends to refer to nerve damage. So the pain can be a little bit more difficult to treat depending on the situation. Nociceptive pain can be further split into somatic, which is usually a bone or joint and gets worse with movement, or it can be very localized and visceral, such as pain in the esophagus or uterus. In terms of neuropathic pain, a lot of people describe it as burning, stabbing, electric shock-like, and then nociceptive pain as being more achy. In practice, sometimes these distinctions are less black and white. So you might find, for example, nociceptive pain like myofascial pain can actually have a degree of burning and stabbing as well. And neuropathic pain, people can definitely describe it as painful. Um, so what's more helpful to differentiate the two would be if you're looking at other symptoms associated with other neurologic damages, such as decreased hot or cold perception, if they have complaint of numbness, weakness, pins and needles sensation, those kind of symptoms can help you differentiate that a bit further. Another distinction you might hear about is between acute and chronic pain. So acute pain is often accompanied by activation of the sympathetic nervous system that we're talking about. So the patient can have accompanying symptoms like blood pressure goes up, heart rate goes up, the person is sweating, those kind of other symptoms. But whereas in chronic pain, the sympathetic nervous system has already adapted over time and often evolved away from that original injury. So the tissue may have already healed, but the pain is persisting. So the goal for acute pain is a little bit different in terms that we want to identify and treat the underlying cause or injury, whereas for chronic pain, you're more focused on longer term management plans like maybe rehabilitation, maybe preventing social isolation, improving functional status, some of those kinds of things. We know that older people account for about a quarter of Canadian emergency department visits, and acute pain is one of the leading complaints. So we will talk a bit more about acute pain here. So some key principles in terms of managing in older adults. As you can understand, many challenges exist with this group. You're probably familiar with many of these already. Pain in older adults, one thing is the presentation can be very non-specific and it can get underdiagnosed or misdiagnosed. They may have concurrent physical or cognitive impairments and communication challenges that make it very difficult to assess and treat them properly. They often have a long and complex medical and medication history to wade through. So often if we want to do a best possible medication history, it can take just half an hour, just or longer, even trying to track down exactly what has been used, what has been tried, what has worked and what hasn't worked. They can have age-related changes that make them much more susceptible to drug-related adverse events. So things like liver impairment, kidney impairment, even things like body composition. So different changes in the skin thickness, if you're talking about topical medications and things like fat composition percentages, those kind of things for fat soluble medications. And of course, age-related bias can exist among clinicians as well. So older adults, research has shown that older adults may be less likely to receive pain medications compared to younger patients. And poor pain management can certainly lead to things like longer lengths of stay and more time for mobility, so more time staying in bed, and things like functional abilities will decline. So one thing that would be important here is to think about it is uncontrolled pain is actually strongly associated with delirium and behavioral issues, so such as agitation, aggression, wandering, and refusal of care, which can all be very important in the ED. There's a recent study that actually showed untreated pain is more strongly associated with delirium than opioids. So, according to the American College of Emergency Physicians and Society for Academic Emergency Medicine, formal assessment for acute pain is recommended to be documented within 1 hour of arrival in ED. And then a second assessment should be conducted if the patient is still in the ED within 6 hours. So this is a framework called the 5 M's of geriatrics. This is a framework often used by geriatricians that can be useful in various settings, actually, but pain management is one of those settings. So they talk about 5 areas of focus: mind, mobility, medications, multi-complexity, and what matters the most. So this is kind of a comprehensive approach to ensure that you consider multiple factors and try to use patient-centered strategies and interdisciplinary coordination. So this framework actually has some research behind it to show that it improves outcome for older adults and reduce low quality services. Mind refers to cognitive impairment, so that can get into in the way of assessment, but also in the way of cognitive behavior therapy and some other therapies where cognition is important. Mobility, it's talking about how if you're trying to get them moving and it may not sometimes be possible for them to engage in full exercise. So just saying, go do these exercises may not work well, and you want to be feasible and practical with the instructions. Medications, certainly polypharmacy is very common in older adults, so people on a lot of medications because of their multiple chronic illnesses. And adverse effects, as I mentioned earlier, are also much more common. So you want to be checking what drugs they're on, how they're taking it, and deprescribe where possible. Multi-complexity or multimorbidity refers to older adults having other concurrent illnesses and social factors that can complicate the picture. So you want to think about other disease states that may make exercise or medication use less effective, socioeconomic factors like barriers in access, etc. And then what matters the most? So that's just speaking to identifying what's important for your patient. Is it mobility? Is it comfort? Or it might be all of those. So this framework is useful when you talk about treatment goals and post-discharge plans with a patient. You want to think about pain severity, but also pain-related things like goals, functional goals, or quality of life goals. So what amount of pain reduction would allow you to accomplish those goals? What about underlying or comorbid conditions? Are there diseases that may be contributing to the pain? Is there mood disorder? Is there vitamin D deficiency? Is there thyroid disorder? Those kind of things can all complicate the picture. Is a patient receiving medications that could actually make the symptoms worse? Or should the patient be on something but is not? Are there symptoms like poor sleep, depression, anxiety, anorexia, all of those factors contributing to the pain as well? So some pain scales have been validated for older adults. I'm mentioning a number of here in terms of following from kind of most communicative to least communicative patients. These generally test pain intensity, pain interference, or both. So the verbal descriptor is something, as it says, it's basically just different words to describe the pain. So such as no pain, moderate, severe, extreme, as bad as it could be. So this could be useful for patients with mild but not severe cognitive impairment. Numeric rating is 0 to 10, and that's probably something that all of you have seen in practice. And functional, actually, I'll talk about phases first. So phases is like basically the same idea as a numeric rating, except you use different pictures. So different pictures that represent facial expression that corresponds to the amount of pain the person is experiencing. So the numeric rating scale and phases can both be used in moderate dementia. There's also a functional pain scale that can be useful for patients who say, well, I don't know what a 4 is, right? I don't know what a 6 is or what the difference is between a 5 and 6. So if they find challenges with giving it a number, you can use a functional pain scale. And then observational tools can be used for patients with advanced dementia or if they're non-communicative or unconscious. So this is based on other people around them observing for things that may be indicative of pain. So I'll go through the Abbey Pain Scale and Pain AD, and just want to mention that recently a team in Australia developed this thing called EPAT, which is an electronic version of the Abbey Pain Scale. And it's meant to assess pain in patients at the point of care. So it's on your phones, and you can quickly put a few things in. And it uses cutting edge technology to match. So if you take a picture of the person's face, it actually kind of evaluates that facial expression and gives you some of that judgment. So it detects facial microexpressions indicative of pain. It's quite interesting. They just validated this tool and showed internal consistency and reliability were both very good overall. And they see that it might be really suitable for non-communicative patients down the road. So functional pain scale. So this is, as you can see, it's a tool to look at a person how pain impacts the daily functioning rather than just focusing on the intensity of the pain. So it's a scale of 0 to 5. So 0 says no pain. 1 is basically the pain is okay, but I can still do everything I like. Whereas 2 to 5, it starts to show limitations on daily activities. And when you get to 5, it's basically I can't even talk about the pain because I'm in so much pain. And this is an example of faces. So the top one is a faces scale. The bottom one is a different version that people have used. I just want to make a note of the bottom one. The bottom one is a bit more cartoonish, you can tell. So that one was actually originally studied in children. That's why it looks a much more cartoonish. So the top one is the one that's actually validated in older adults, but both, I've seen both being used. This is a Ping AD scale. So this is for patients who are unable to self-report. So self-report is considered gold standard as Ping is very subjective. But if the person cannot self-report, then you can use a number of these domains and assign them a score between 0 to 2. So the higher the score, obviously, the more problematic the pain is. So one thing to note is that some of these behaviors can also be found in agitated delirium, not just in pain. And some agitated delirium can be caused by uncontrolled pain, right? So there's a lot of crossover, and sometimes it's really hard to decipher which is which, but you want to just be mindful of that. And treating the pain is a good start because we know that once you treat the pain, the evidence actually shows that there's less agitation and less behavioral symptoms. So this is an example of the Abbey Pain Scale. Very similarly, this is also an observational tool for those with dementia or difficulty communicating. So this one, the Ping AD is generally considered to be a little bit faster and easier to administer, but this one also has good reliability and validity. And once you try these tools, you'll figure out which one is the best suited for your particular population. So let's take a look at a case with an older person with multimorbidity. So this is a gentleman who has advanced age, osteoarthritis, coronary artery disease, heart failure, hypertension, and has a health aide living at home with him. And he's complaining of severe shoulder pain that gets worse with movement, which means that now he's limiting his daily activities of daily living, mobility, moving around in his home, even pleasurable things like he used to enjoy to play on his iPad, but now he can't do it or he doesn't feel interested because of the pain. So he's becoming a lot more isolated. His mood is becoming less great. He's still sleeping okay and he's eating okay. But right now he's basically ranking his pain as a 10 out of 10. So he really would like some help with that. So what do you think? And I guess I don't know what the best way is to do this. Maybe just let me see if I can see the chat. There we go. And Oh, thank you. Somebody put the link to the EPAT in there. Thank you very much for that. Great. Um, and yeah, if you want to throw out some goals that you might want to focus on for this patient, acute goals, longer term goals. Um, and I'll continue to chat a bit about the goal setting. So the goals of acute pain management usually is set on reaching an acceptable level of pain here. So you want to understand patient and family wishes and set the expectations. Zero pain is often not possible. It may be possible in some cases if the injury can make a total recovery, but it may not always be possible in other situations. And the focus will be more about how to self-manage, how to live with the pain and keep the person functional. And one thing you also want to think about is minimizing treatment-related adverse effects. We know that iatrogenic harm is a real thing, and medication-related emergency visits is significant. So always keep that in mind for the older adult. Since pain treatment is often continued post-discharge, it will also be important to think about the treatment plan with the life beyond the ED in mind. So here for this patient, you might want to think about things like having the person hurt less so he can become a bit more mobile, maybe get back to his baseline, maybe playing on his iPad more, maybe preventing that social isolation. One of the goals that he and his children have agreed to is basically they want to go back to maintaining what he was able to do at home previously. So that could be a goal that could be worthwhile. So at this point, what else would you like to know? So this is thinking about assessment. So you already know a bit of that presenting picture, right? What else would you like to know in terms of things that you want to find out from him, his family, his health aide, current medications? Yeah, that's a great point, right? What else is he taking? What could be making it better, worse? What has he tried? Yeah. Excellent starting point. Any falls, trauma? Yeah, great point, especially if he has mobility challenges. What has he tried? Yeah, yeah. Always a good starting point. Because if he has just tried something, you don't want to be spending your time to go, hey, you should try this again. Home supports? Yeah, excellent. Does he live alone? Yes, in this case he does, but he has a living health aide. Um, so he does have some support. Easing factors for pain. Yeah, that's great, right? What makes a pain better? What makes a pain worse? And bilateral or baseline history regarding mobility and ADLs. Excellent. Yeah. What does he want to have happen? Yeah. What's he willing to do? So his goals to incorporate into your care plan. Mobility device. Yep. Yeah, lots of great ideas in there, right? So you might want to, yeah, there's medical history, medication history. You might want to ask about his allergies. There's a pain history, which a lot of you have mentioned. So what's been tried, what worked well? Is there a timing to his problems? What are triggers? Does he do something that makes the pain a lot worse? And social factors, right? What's his financial situation like? Does he have access to medication? Can he reach follow-up care? Can he reach things like physiotherapy, right? All of those factors might come into play. Does he have a device that needs to be reviewed for fit? Yeah, that's a great point. Maybe it's no longer a good fit. Okay. So let's move on. So he's not a surgical candidate, and he tried some steroid injections in the past, but they're no longer working that well for him, which is quite common to see. And right now he's just using acetaminophen, 1 grams, 3 times a day. So what do you want to go from here? If you think about the modalities of treatment, do you want to go with pharmacological options first? Do you want to go with non-pharmacological options first? I mean, I think eventually we all agree that it'll be a combination, right? But do you have a do you have a do you have thoughts on where you'd like to explore first? Non-pharmacological, okay, great. Well, we'll follow right along then. And we'll talk about non-pharmacological. Oh, there we go. So non-pharmacologicals. So there's a lot of research on this, but this is a JAMA published clinical review article from a few years ago. What the nice thing about this is they actually went through 35 different studies of pharmacological interventions and 57 studies of non-pharmacological interventions. And they did a very nice sort of evidence-based review on this. And now all of these modalities have shown to a certain degree to decrease pain and increase function, but this is listed in order of the strength of the data behind them. And one thing nice about non-pharmacological approaches is that they all have a very low side effect profile. So they're generally pretty safe for the older adult. And this is focused on older adults, by the way. So the strongest evidence exists, probably not surprisingly, is for exercise. So this is very consistent with other meta-analysis that have been done in this area. Several studies have shown that exercises reduce pain compared to usual care and improve physical function. Most of these patients studied had osteoarthritis, and the largest group was osteoarthritis of the knee. So not surprisingly, using exercise has the highest recommendation for pain from both American, British, and geriatric societies. The second largest effect size was seen for cognitive behavior therapy, and I'll talk a bit about that on the next slide. And then other things are a little bit more moderate, so not as strong, but you can see there's a lot of uh, literature related to massage, acupuncture, tai chi, etc. Now, other things that you may have seen, meditation, for example, those have weaker evidence. So I didn't include it on this slide, but if you're interested, you can go to the full article and it does list the weaker evidence ones as well. This choice can be quite personal. And by the way, one caveat is that this evidence is focused on largely in chronic pain. So there isn't a lot of evidence in acute pain. But in terms of how effective it is, this can be used as a nice guidance. So acceptance from the individual person will influence continued uptake a great deal. So if the person says, I don't believe in yoga, then it'll be probably much harder to convince them than a different form of similar exercise. And the other point to keep in mind is that most of these will take time to see effect. They don't work right away. So for acute pain, you will have seen, I think there was a question about heat. So excellent. Acute pain, you'll note that there's alternative non-pharmacological therapies, such as positioning the person, heat and cold, etc., applications on the spot. So these have not been really well studied in the emergency setting, but you will probably see literature about these in other settings. So they haven't been well studied for feasibility and effectiveness, but because they're pretty easy to try, you can certainly try them on an individual basis, depending on the type of injury. So this is a kind of a more detailed slide out of this, this article this is a meta-analysis that focuses on cognitive behavioral therapy. So when we talk about cognitive behavioral therapy, we're talking about three components: patient education, behavioral skill training, and cognitive skill training. And these can be delivered one-on-one in a group. They can be online, over the telephone, or in person. So there's a lot of variety in terms of these kinds of literature. But this meta-analysis looked at 22 trials and randomized control trials over just over 2,500 participants. The mean age was 72 years, so this was in older adults. And the main duration of therapy was 9 weeks. And most people had about 8 sessions to complete their study. The follow-up was on average about 6 months, but some studies did go up to about a year. So what this shows is this is pretty high quality data since this is all randomized controlled trials. But what this shows is that cognitive behavioral therapy decreases pain intensity, decreased the tendency for the patient to catastrophize, and improved self-efficacy. Not as much difference in pain interference or depression, anxiety, and physical function. So when you pick and choose the right patient, that might give you some guidance in terms of who might benefit from these cognitive behavioral therapies. There was no reduction in the amount of pain medications they used or opioids that they used. But the nice thing is they were seeing sustained benefit for up to a year for the follow-up period. Okay, so moving on to medications. The good news is there's a lot of different options and different mechanisms that you can try, and some can be quite complementary or synergistic. The bad thing is there's not one best option, and they can all cause different levels of side effects. The ones marked with that asterisk, in particular, are drugs listed on the Beers criteria, which is a list of potentially inappropriate medications for use in older adults. And usually this is due to safety reasons. So this list is published and updated regularly by the American Geriatric Society, and you can find the full list online quite easily. Um, so we'll go through a few of these categories. Oh, sorry, went way too fast. Uh, my mouse is faster than I thought. Okay, so if we're starting off with choosing a pharmacological agent, or I guess we'll go to, there we go. Okay, so the simple thing that people always say is choose your agent and individualize your choices. So what you want to do here, one is look at the type of pain, and the other is the safety profile for the medications. So not all agents are good choices for older adults, even if they're very effective for the condition that you're trying to treat. A good example is tricyclic antidepressants like amitriptyline, for example, super effective for neuropathic pain, first line, excellent number needed to treat, um, but not first line for older adults because they're also strongly anticholinergic. So if you must use a TCA, then nortriptyline and disopramine are recommended actually precisely because they're less potent as anticholinergic medications. So it's a little bit counterintuitive in that sense. Adjunctive agents like antidepressants, anti-convulsants, those will take days to weeks to work, and so you will need to give it time. The other thing people often say is start low and go slow. I will just add a bit to that and say don't forget to go because you do want to get the person into an effective dosing range. If the dose is too low and the drug is not actually doing anything, you might as well just get rid of it instead of keeping it at that low dose, unless you're doing that low dose intentionally for synergistic or complementary, like adjunct effects. Many side effects are temporary, and this is something you could reassure the person with. Some medications that you do not want to use in older adults, meperidine is one, mostly because of that active metabolite accumulation, especially if the person has renal impairment. There's also neurotoxicity, and ketorolac because of the highest risk associated with gastric ulcers, pentazocine with delirium, and indomethacin for CNS side effects. So if you must choose an NSAID, anti-inflammatory pain medication, stay away from indomethacin if you can help it and choose one of the other NSAIDs. So acetaminophen is often the one that's considered the first line in terms of pain management. And this is mostly because of it's got a fairly, I would say, gentle side effect profile. It acts on the CNS, so it acts in the brain to decrease pain perception. It's not as effective as nonsteroidal anti-inflammatories like um, uh, ibuprofen, for example. It's not as effective, especially in acute and chronic spine-related pain, but it can be effective for all over pain that older adults sometimes complain of. It's got good evidence for osteoarthritis, especially multifactorial multi-site pain, in which case acetaminophen would be a mainstay first line of treatment. Um, So the question might be that if for older adults, we're aiming for a lower dose, so probably anywhere between 2.6 to 3 grams a day. So this person right now is on 3 grams a day. So what do you think we should do next? Is he a candidate for things like NSAIDs? Might you want to go with something like opioids? And I guess the other question I'll throw out there is, would you discontinue the acetaminophen if you switch or add, if you add on a different medication that's a little bit stronger, right? Yeah. So there's comments in the chat about cannabis and compound cream. Yeah, I will talk about both of those in a second. Yeah, so so acetaminophen, one of the benefit is actually that it can be opioid sparing. So if you're going for a weak opioid or something one level up with with that stepwise approach we talk about in pain management, you want to keep the acetaminophen. It'll probably still provide some benefit. And in older adults, you want to schedule it regularly because then they may not, one is they may take too many if they just take it as needed. And the other is that they may wait too long to take it. So the pain might be a lot worse than it would have otherwise been. So we generally recommend if you are using acetaminophen as that baseline buffer, then schedule it as a regular medication and schedule it for that safer dose. Okay, so someone in the chat just mentioned about compound cream, so excellent point. Topical agents are much safer, so topical NSAIDs would be the recommended thing to go to if you want to try NSAID. Systemic NSAIDs are associated with other side effects like GI or renal toxicity. And there's good evidence on topical creams, especially in older adults with osteoarthritis. Topical lidocaine is another example. It's an anesthetic that the IV is not recommended in older adults because of it's actually contraindicated in patients with pre-existing cardiac disease and also used with caution in patients with hepatic renal failure. So for lidocaine, we really just recommend the topical if you need to use it, but it's available as a patch cream, and you can compound it in combination with topical NSAIDs, and sometimes people throwing a topical TCA like amitriptyline when there's a neuropathic pain component. So it's quite flexible since you're getting it made for the person, and lots of compounding pharmacies will do that for you. So if you're wondering about the efficacy, topical diclofenac is about equivalent to an oral NSAID in terms of the benefit. One thing is if you have a large area that you need to apply to, then that may not be suitable. Now you're getting lots of absorption, and also it gets quite expensive. These are not cheap drugs, so these are a little bit better for localized areas instead of all over the body kind of pain. Topical capsaicin is another example. So this is the chemical that's responsible for the heat in chili peppers. So what they do is they kind of burn out the nerve endings, this thing called substance P, which then make the nerves less effective in new pain transmission. So one thing is that you need to use it repeatedly. It doesn't work right away. You need to build up that loss of function in pain transmission. And then the other thing is because it's that thing that's in chili peppers, you definitely do not want to rub your eyes or mouth afterwards if you use your hand to apply it. Right? So that can be very uncomfortable for the person. So if the person has cognitive impairment, you'll want to be careful with how that's administered. They might need some help with administering, and because they might actually forget and then just touch their eyes after. So it's a little more complicated. And you also have to apply it multiple times a day. With all of these topical agents, it's usually multiple times a day. And oral agents. So if you are going up to NSAIDs as the next step, NSAIDs are considered to be a part of the Beers criteria medication list. So they are very effective, especially for MSK related pain. The problem is when used long-term in older adults, they can cause toxicities. One is GI, right? The other is renal toxicities, and they can also improve or increase, not improve, increase blood pressures and things like that. Um, so they are recommended, they're effective, but they're only recommended to be used short term and at the lower doses if possible. And if you must select an NSAID, here's a few tips. Some things that you want to think about. What are you concerned about in your patient? If it's cardiovascular, then drugs that are a little bit better would be naproxen, celecoxib, ibuprofen, and you want to stay away from the higher risk, like indomethacin, for example, that we talked about a bit earlier. If the person has a high GI ulceration risk, then you want to be looking at either adding on a PPI or a use a selective COX-2 inhibitor like celecoxib, which is a little bit safer. And just keep in mind the other side effects will be the same in terms of risk. And COX-2, if you're using PPIs, long-term use can also lead to other things like dropping magnesium and osteoporosis. Um, so if the person has a degree of neuropathic pain, um, then the the most common agents that you will see would be anticonvulsants, what we call the GABA agents, the pregabalin and gabapentin, or the antidepressants. The most common ones used in older adults would be the SNRIs. Duloxetine, venlafaxine, probably your most common ones that you will see, but they all work kind of, they have similar efficacy and different side effect profiles. So pregabalin and gabapentin, one thing to watch out for is falls in this population associated with CNS impairment. And the other with the SNRIs, they can be very helpful if the person also has coexisting depression or general anxiety disorder. So that could be a good add-on if the person has those kind of comorbidities. Muscle relaxants. So this is something that we basically only see used in short term for acute pain and not used very much in long chronic pain, or maybe only used sparingly or as needed in chronic situations. But in acute pain, you can try one of these two classes depending on the condition you're looking after. One is antispasticity agents, and the other is antispasmodics. So the antispasmodics are a bit more have higher risk associated with triggering delirium, and so basically a higher risk profile. Um, the safest medication in older adults is of this group is probably tizanidine, but unfortunately it's no longer manufactured, so you might have to go with one of the other agents. Um, it in terms of older adult data, it actually has less false and less adverse effects related compared to baclofen and dantrolene. But keep in mind, these are just short-term use, and you want to monitor closely because of these related side effects. Opioids. So this is something that a lot of you probably will have in your minds when you think about pain management. There's been a lot of conversation about opioids in older adults, and especially in recent years, right, when we talk about the harms associated with the opioids. So opioids attach to opioid receptors on nerve cells and then block the pain messages from going to the brain. So compared to NSAIDs, they can decrease pain and improve function. They're probably about as efficacious as NSAIDs, but different side effect profiles. So which one is better or worse, right? Opioids can cause lots of NSAIDs we talked about all the issues associated with NSAID use, but opioids can cause falls and fractures, which will be a big issue for this population. And that's very well proven. They can increase hospitalizations, they can increase ED visits, and they have other tolerance issues like constipation. And a lot of people are worried about overdose and addiction. So in older adults, they actually have less risk of addiction and overdose as compared to younger populations. And this is just a matter of accumulated data showing that. Um, most of these are dose related. There's various factors for this. One is older adults are considered to be a bit more, they take this for pain, so they follow the directions and they're less likely to engage in recreational use and experimentation. But that's not to say that doesn't exist, but just compared to younger adults, the risk of overdose is a little bit less. If they're on a stable dose of opioid, the risk of overdose and addiction is actually less of a concern than the risk of falls and hospitalization for this population. If you can keep them to a lower dose, the less risk of falls and fractures will result. So that's actually worth doing. So the dose matters in this one. If you must use one, try to use the lowest dose possible. Side effect profiles are quite consistent across most agents. Most of these tolerance issues like nausea, sedation, those kind of things tends to go away with once tolerance develops. The only thing that does not go away is constipation. So a bowel routine is recommended if your older adult is on this for longer term. Um, Opioid risk tool. So this is a commonly used tool used to assess the risk of misuse associated with opioids. So you can see that on the age part, if they're a younger age, they get an extra point. And this goes back to the data shows that if you're older, you actually have less risk of misuse. So basically, if you add these up, this is very quick to do. What this says is that if they have a personal history of substance misuse, then they have a higher risk of opioid misuse down the road. And this is also reflected in the guidelines where they talk about how you want to be really careful starting opioids if they have an active substance use history. You probably do not want to start opioids in them, but if they have a past history, you also want to be careful and start them with the lowest dose and keep monitoring. So selecting opioids, many things you can consider, right? So there's the potency, there's side effect profile. You can think about things like if you want to look at the higher potency agents, it's not recommended that you start people who are opioid naive directly on them. So usually you would start them on something like morphine and then convert them over even gradually as you determine a stable dose that would be necessary. And you want to reduce the opioid dose starting by probably 25 to 50% in this population and then titrate them up gradually if they're opioid naive. One quick comment about tramadol is that tramadol is sometimes people talk about it, it's a bit polarizing in terms of people who want to use it or not. It does have a ceiling dose. It's not a clean opioid. It does have some serotonin or epinephrine, so SNRI action. Some people like that because they think it's effective in using dual mechanisms, but some people do not. It can also cause seizures as well as hypoglycemia. So it's not something that you'd probably go with first line, but if they're on it, you can continue the person on it with monitoring if they have good results from it. So this is just a reference chart about converting opioids from morphine to morphine equivalent daily dose, depending on the drug that that you want to switch them to. A few quick notes about other agents that you might want to, or you might have seen. Buprenorphine is one of those that's getting there's actually increasingly a lot of evidence in this. So in Canada, buprenorphine is available for chronic pain. It's also used for substance OUD, so opioid use disorder, but in terms of pain, it's just approved for chronic pain. But it is approved in the US for acute pain as well because it's available as an IVIM injection. So it's buprenorphine, I think, will start to get more play for chronic pain in older adults because really it has less side effects that we're concerned with opioids, but it has good efficacy. So it can provide full pain management. It's got It's has less respiratory depression, so overdoses are very rare, and respiratory depression is very rare. Additionally, there's no euphoria, so addiction is also very rare, and there's slightly less constipation as well. So some of the benefits associated with buprenorphine. Cannabis. So this was mentioned a bit earlier. So I think the quick answer is there's not a lot of data for this indication, but probably you'll see patients asking about cannabis or cannabinoids for pain. So this in the studies that we do have one is the data is focused on the younger side of the population. We do have a few studies with patients who are around 75 years old. It's not a lot of data, but what they showed was that cannabinoids decrease pain by about 50%, but there is still a 10% withdrawal because of side effects. So it's not completely side effect free. And then keep in mind that a lot of these studies are sponsored by the cannabinoid industry. So there's a degree of bias that may exist. So the best evidence we have is probably in pain coexisting with sleep disorders. So if you have patients that fit into that window, this might be a choice they want to explore. So with Mr. M going back to the plan, you want to set up a short-term plan, so probably looking at analgesic control, and then a longer-term plan. That's where you could incorporate other things like non-pharmacological options, adjunct to medications, and work out a patient-centered plan with a lot of the considerations that you've already mentioned under the chat box. Really quickly, two other things I just want to mention. Ketamine. So this is something that you have seen probably in different news reports. So this is an older anesthetic that's gaining popularity because they use it in low doses for difficult to treat depression. So they have started to use this intranasal ketamine in older adults with acute pain now. So this is acute MSK related pain. And they showed that it was non-inferior compared to intravenous morphine. And the adverse effects were quite mild. And they didn't have to use a lot of rescue medications, so breakthrough pain treatment. So this is something that's still kind of, they're exploring this for emergency departments to look at treatment for older adults with things like rib fractures, for example. Basically, they want to use it as an opioid sparing agent in people whom you don't want to use opioids for. So lower risk of adverse effects, but they did report some hallucination and delirium. So basically, I think you need more trials in terms of that acute trauma-related use, but potential as opioid sparing adjunct to medication. The very last one I'll mention is inhaled methoxyflurane. So this is an anesthetic medication, and low doses have been used for, oh, sorry, low doses have been used for as an analgesic for moderate to severe trauma pain, and predominantly only used in the emergency area. So some side effects are nausea, sedation, confusion, and but the adverse effects are generally considered quite comparable to other analgesics. So that might be another option if you need it in that emergency setting. Right. So I'll leave these last considerations for you and see if there are any quick questions on the board.
Thank
Oh,
you so
thank you.
much. You do have a couple questions about Tylenol. One question specifically thoughts about Tylenol 3, but an earlier question about older adults self-medicating with Tylenol arthritis. Any reflections about Tylenol?
Yeah, so Tylenol, the main thing to keep in mind, one is safety. So it's available in lots of over-the-counter medications and prescription medications, actually. So if they're treating for sleep, it's got Tylenol in it. Some combinations, cough and cold medicines often have Tylenol in it, right? So one thing is to make sure that you know what they're taking and to educate them about out that they should really read the label, or if they're unsure, go with the pharmacist and have them recommend something. Make sure they add up all the Tylenol they're getting so they're not accidentally overdosing. Um, and then the other thing is, I usually always prefer them to use single ingredient medications over the counter for symptom treatment. It's just much cleaner, much easier to manage. But there's lots of advertising that talks about, and the label is very misleading in lots of cases. It might just say cough and cold, right? It doesn't mention anything about pain there. Um, so the you can use this, so the dose will matter. If they have liver disease, you want to bring the dose down quite a bit. It's not impossible to use, it's just you have to be more careful with the dose. Generally, older adults, nothing more than 3 grams a day. Sometimes people recommend even lower, like 2.5, 2.6. But you're looking also matching that with the effect, right? So how much effect are you getting out of that dose? Is it worthwhile? Tylenol 1, 2, 3s have codeine in them. So that's something else. So you're basically taking this, it's got caffeine too, but it's small amounts. But you're basically thinking about it as you're getting an additive amount of Tylenol with codeine. So codeine gets converted to morphine. So it's essentially morphine you're talking about, except codeine is um, different. So there's a genetic component in that. Some people do not metabolize codeine very well. So they might be taking high doses, getting lots of Tylenol, but getting very little effect out of that codeine. If that's the case, they should just discontinue the T1, 2, 3s and use plain Tylenol with morphine. And they might be able to get actually much more benefit if that's the case you're seeing. And codeine is worst for constipation. So that's the other thing that makes them less desirable. Um,
Thank you. I know there are some other questions in the chat. We'll need to probably let you go. Thanks for the link there, Deb, around the codeine increased risk of all cause mortality, a study
mhm,
linking the those two. And also Becky just noted in the chat that there's a current study underway with EMS around inhaled methoxyflurane, and you mentioned some contraindications for older adults. Anything else we need to think about there?
yeah, I think you're going to continue to see more evidence in for those. I wouldn't say they're newer drugs, but they're kind of newer indications of use anyway.
Okay.
But it's always good to have more tools in your arsenal, right?
Great. Well, thank you for what a extensive presentation and such a lot of information. You did a great job distilling a huge topic in a short space of time. Really appreciate you taking the time this morning to share your wisdom with us, and I think you've piqued people's interest, and there's lots more to watch for. I'll just pop back in the chat for everybody just the links that you need to know about to get to where you want to go. We do have a lunchtime drop in, so there's a link that you can go over and meet people and say hello just informally. Bring your lunch. That might just look a little weird on Zoom, but go ahead. And and the last is really just to know we start back at 1 o'clock for the afternoon sessions. It is a different link than the lunchroom, so just take note of those two. You can follow along on your copy of the agenda as well. And Dr. Chang, I saw some hands, some reactions, people clapping for you. So I hope you can hear it. And thank you again for your time today.
Thank you all. Thank you for your attention. Great discussion.
All right. Bye, everyone. We'll see you either in the lunchroom or at 1 o'clock.